Hello, this is Neil Hansen. I'm a diagnostic radiologist in Omaha, Nebraska, and I'm here to deliver the next in the series of physics lectures we've prepared. This is an MRI lecture titled Clinically Oriented Pulse Sequences. It's basically a continuation of the prior lecture. For Poll Everywhere, I encourage people to click on the link within the description of the YouTube video to go ahead and open Poll Everywhere as a quiz or a survey. What you can do is I ask questions every 5 to 10 minutes to keep people awake, engaged, and doing something. I find if you at least click something every once in a while, you will stay awake and the head nods will be decreased. So I encourage you to open that up and do the questions along with the lecture. These are references for this exam or this lecture. You can use either of these textbooks or Physics Core Machine or your own references. I covered references more thoroughly in the prior MRI physics talk. Here's the Poll Everywhere link, which you can also use to open up the survey. Again, I'd just like to highlight these two books, which I personally found very helpful: the Case Review series of Duke Review of MRI Principles, as well as MRI Made Easy for Beginners. That MRI Made Easy for Beginners is a good book to read just initially. It's very, very simplified, a way to just get your feet wet for MRI. Again, I'm not an MRI expert in terms of physics, but I do play one at work. I'm an expert. Get the frickin' sharks with laser beams on their head. Am I too old for that reference? I don't know. I am no cactus expert, but I know a prick when I see one. All right, pulse sequences. So what is a pulse sequence? We talked about these pulse sequence diagrams last time. Kind of the basics of them. A pulse sequence is basically just a pre-programmed set of changing magnetic gradients and imaging techniques for MRI. We change the parameters for the task at hand to differentially evaluate tissues, whether we want to see things that are fluid sensitive or whether we want to take advantage of contrast enhancement. All those will require different setups. If we want to nullify all the signal from fat in a sequence, we'll have to do special things. There are numerous changeable parameters. So what can we control? The machine control the flip angle of the initial radiofrequency pulse. We can control when we listen for the echo. That's the TE. We can control how often and how frequently, as well as what time we repeat the whole thing. That's the TR. We can throw in an inversion pulse. Inversion pulses are usually meant to nullify something like water or CSF. We can control the matrix and the field of view size. We can control the echo train length. We can control how it's reconstructed within K-space. And we can control 2D versus 3D image acquisition. We can also control whether there's contrast on board or not. To go back to the concepts of TE and TR that we initially discussed last time, I'd have you remember that MR signal is really just the echoes of the transverse magnetization created by the initial RF pulse. The TE is the time to echo. It's under operator control. It's the time from the initial pulse to the echo receiving. If you remember here, initial pulse to echo receiving, this is when the echoes are occurring, and this is when we listen during that TE time. Short TEs mean that there's little loss of transverse magnetization, so there's little T2 weighting effect. So if you don't want much T2 weighting effect, you're going to have a short TE. TR is the time to repeat. It's the time in between the initial pulse and the repeat. So from the time of the initial pulse to the time when the whole thing is done and we repeat it, that is defined as time TR. I'm going to show a quick video because I think it illustrates a lot of important things to better advantage than I can talk about.
Water molecules, while others are fixed in position associated with the structural or energy storing molecules of protein and fat, they have characteristic differences in their T1 and T2 relaxations. We can accentuate and measure these differences by changing how quickly we put in the radiofrequency energy, or the repetition time designated TR, and how quickly we choose to listen to the signal coming back from the transverse magnetization, or echo time designated TE, of the precessing protons. This process is referred to as the pulse sequence, and we will use a sample of fat and water to demonstrate these differences.
Great guitar riff.
As before, to simplify and maximize comprehension, we're going to stop the precession of the protons. On the left is a group of spins or protons associated with fat, and on the right, water. When we put in our resonant radio frequency pulse, all the protons absorb that energy, flip into the high energy state, and spin together to produce our 90-degree pulse or transverse magnetization. If we wait a sufficient amount of time, the protons will move apart in a T2 or spin-spin relaxation, and the transverse magnetization will decay. The protons associated with the free fatty acids, being relatively fixed in position, decay rapidly as the spins push away from one another. They also give up their absorbed energy more rapidly as they fall back to baseline in a T1 or spin lattice relaxation, depositing heat energy into the surrounding tissues and regrowing the longitudinal magnetization. On the other hand, the protons in the freely flowing water can hold on to their energy and continue to spin together in phase, thus maintaining the transverse magnetization. At this point, when we turn on our receiving coil and measure the signal coming back from the protons, the relatively large transverse magnetization in water will give a strong signal, while the smaller or absent transverse magnetization in fat will give a weak signal. By convention, the strong water signal will be assigned a grayscale color of white, and the weak signal of fat will be dark gray or black. Hence, to accentuate the different T2 relaxations of the protons in our bodies, we would wait a long period between radio pulses, referred to as a long repetition time TR, and wait a long time to listen for the return signal or echo, referred to as a long echo time TE, and these differences can be measured and recorded. Using these same tissues in their baseline state, to accentuate the differences in T1 relaxations, we again put in our 90-degree resonant radio frequency pulse, which flips the protons into the high energy state and pushes them in phase to produce our transverse magnetization. T2 relaxation occurs as the protons move apart, faster in fat than in water, and then the protons fall back into the low energy state, dissipating the absorbed energy as heat into the surrounding tissues and regrowing the longitudinal magnetization. Again, because the protons in water are fluid and move freely, they tend to hold on to that energy longer, and the protons stay in the higher energy state with little regrowth of the longitudinal magnetization, whereas the tightly packed fat protons more rapidly give up that energy and return to the low energy state, thus rapidly regrowing the longitudinal magnetization. If we then quickly put in another resonant 90-degree radio frequency pulse, the fully recovered fat protons will produce a large transverse magnetization and a strong measured signal that we can record if we listen to the return signal or echo shortly after the second radio frequency pulse. However, the water protons are still in a high energy state with little regrowth of the longitudinal magnetization. Therefore, the new radio frequency pulse flips more of the low energy protons into the high energy state and can only produce a small transverse magnetization as well as a net longitudinal magnetization oriented 180 degrees or directly opposite the main magnetic field. This configuration in the water protons will give a low amplitude or low energy wave when we listen for the echo or return signal. In other words, the protons in the water are saturated with energy and can no longer produce a strong transverse magnetization. Therefore, to accentuate the differences in the T1 relaxations between the protons in fat and water, we want to rapidly put in our resonant radio frequency pulses, or a short repetition time TR, and quickly listen for the return signal or short echo time TE. Now, this is a difficult concept and you may have to listen to it a few times to get it to sink in, but to summarize, the T1 relaxation effects are accentuated by rapidly exposing the protons to radio frequency energy and keeping the spins in the high energy state, and thus reducing the effective longitudinal magnetization. Tissues that recover quickly will have a large signal, while those slow to recover will have a low signal. T2 effects, on the other hand, are accentuated by a prolonged echo time to allow the spins to move away from each other and accentuate the differences in T2 relaxation between regional tissues or chemicals. So a T2 weighted image is obtained with a pulse sequence of a long TR and a long TE, decreasing the T1 effect with the long TR and enhancing the T2 effects with the long TE. A T1 weighted image, on the other hand, is obtained with a pulse sequence of a short TR and a short TE, enhancing the T1 relaxation and minimizing the T2 effects. In between these two is the proton density pulse sequence, which is obtained with a long TR and a short TE, effectively minimizing the T1 and T2 effects and basically giving us an idea of the absolute number or density of protons in the region. The first to propose the use of NMR.
So there you have it. If you can understand all that, you'll be good with pulse sequences. That guy explained it very well. I have a little bit of a man crush on him. Would like to have a bromance. I'm not going to lie. That guy is so good at physics. All right. The infamous spin echo. Traditionally, the most common pulse sequence that's used to teach MRI. It's actually kind of rare to do in clinical use right now. Most of the pulse sequences we use clinically are a little bit more sophisticated than that now. It could be the spin echo sequence, where you just basically put spins on protons and then listen for echoes. It can be T1 rated, T2 rated, or proton density rated. Again, I'm going to show a video real quick because I think really having a basic foundational knowledge of what a spin echo sequence is very important. All of them are pretty much the same. They start with a 90-degree RF pulse, which gains maximum transverse magnetization. And why is that? Well, once you get into the transverse plane, all those protons rapidly push apart and dephase because of those T2 effects and those T2 star effects. So those spin-spin interactions, once you're at that 90-degree pulse in resonance, those push apart and then it causes that signal, right? The signal that we detect, the free induction decay, as they push apart and go back to their baseline status. So really it's the spin rephasing. So spin rephasing is achieved with a 180-degree pulse, so at half the echo time. So why do we do this 180 pulse? So first you do the 90-degree pulse to put them all in resonance, but then you have to get spin rephasing because they're all pushing apart, getting rid of that free induction decay. So you hit them with 90, then you hit them with 180, and they are all in resonance again, which maximizes out your free induction decay, kind of starts it all over, and gets you the maximum signal to detect. So I'll pause now and go in and do the video here because I think it explains it maybe a little bit better than even what I can.
Okay, starts to decay away, so they're out of phase. So if we were measured at this time, we see the signal is diminishing. They get out of phase, it tends towards zero, and then we flip them around the other way in the rotating frame reference, the fast ones catch up with the slow ones, and there we go. A sort of bada bing, bada boom, they refocus, and we measure them now, the signal comes back. And if we let it go further, the signal goes away again.
So there you have it. That's the basics of a spin echo pulse sequence. There's dozens of videos online. I think there's videos out there going into details about a spin echo pulse sequence that are even up to a half hour long. Watch whatever you need to kind of understand it because it's pretty important. But basically, a spin echo sequence usually has a 90-degree pulse that causes the transverse magnetization. Then it's hit with a 180-degree pulse. Why do we do that? Well, there's a couple reasons. One, it negates all the T2 star effects and magnetic field inhomogeneity, right? Because if you do that initial 90-degree pulse, everything starts to push away, and it just functionally buys you more time by rephasing all of the protons 180 degrees opposite, which allows you to get signal in a little bit of a slower fashion. That was very important in the early days of MRI technology because things just couldn't run fast enough. with improvements in technology, a lot of these sequences are now obtained according to a fast spin echo technique, which does different. We'll get into that later on. But early on, especially, all of the pulse sequences were really this kind of variation of a spin echo. All right, so now we need to move on to some specific pulse sequences, what they're used for, and things like that. So we're going to talk about a T1 weighted image initially. Fluid is dark on a T1 weighted image. So if you have CSF or the bladder or something that you know contains fluid and you're trying to figure out what sequence you're looking at, the first step that I usually do is look at fluid, like in this case CSF in this brain MRI, and see if it's bright or dark. It's dark, so I'm immediately thinking that most likely this is going to be T1 weighted. Only a few things are inherently T1 bright, so if you have a T1 non-contrast MRI and you have something that's very bright, you can immediately limit your differential diagnosis. And I always like to quiz my residents. What are the 5 or 6 things that are inherently T1 bright? Fat is, contrast is, some flow is, so sometimes you'll see T1 bright flow in a vessel. Melanin is, so when you look at metastatic melanoma cases. Blood and protein are. That's probably some of the more common pathologies that we see. That is T1 bright is hemorrhage and hemorrhagic blood products. Those are the most common things that you see. Some states of calcification can be T1 bright as well. What are the highlights of T1 weighted imaging? Well, you have to have a short TR and a short TE. Having a short TR minimizes the T2 weighting effects, right? And the short TE kind of maximizes the signal from T1 effects. This is what T1 weighted images is good for. They're very good for anatomy. You can get exquisite detail, and the most common thing they're used for is pre and post contrast imaging. So just a couple examples, like I do a lot of body MRI. So most of the liver protocol MRI, pre and post contrast, is done as a T1 weighted fat saturated image, pre and post. So on the post contrast image, if you know if it's bright and it wasn't bright before, that has to be contrast enhancement, which implies, vascularity or a tumor or a hemangioma or something like that. Here's an example of a T1 weighted image on the left, and this is a T1 weighted image post contrast. You can see this person had leptomeningeal metastases, and they had this thickening, enhancing masses along their leptomeninges. They weren't real obvious on the T1 pre-contrast or really pop out after contrast. The only difference between these two sequences, again, is contrast, so you know that this has to be a vascular enhancing abnormality. Here's an example of a T1 weighted sagittal image through the pelvis. You see a mass in the bladder that's T1 bright. It's inherently T1 bright, so again, only about 5 or 6 things can be that bright on T1 weighted imaging without contrast. This happened to be a large pelvic dermoid tumor, which had fat. You could do a fat sat sequence, see that this signal would go away and prove that it's fat, which is usually part of our pelvic MRI protocol, especially in women. But to diagnose something as having macroscopic fat in it, you can use T1 weighted imaging for that. This is a pre-contrast T1 weighted image in a melanoma patient that had melanoma liver metastases. Again, the metastasis was inherently bright on T1 because melanin is inherently bright on T1. T1 weighted imaging. So most commonly, as an example, you'll be shown a T1 weighted spin echo sequence. These by definition have a short TE and TR. A long TR would allow all that longitudinal recovery of magnetization. So if we waited long in terms of our TR, all the T1 weighting would be gone because all of the longitudinal magnetization would be recovered. So if you look here, if we're doing a graphical representation of T1 weighted imaging, we have to image here on the short T1 times because inherently tissues that have short T1 properties and long T1 properties are differentiated here. If we waited out here to do a longer TR, these two different tissues wouldn't be able to be differentiated because they both will have fully recovered their longitudinal magnetization. So just remember this: short T1 weighted imaging, short TR, short TE. The short TE again is to minimize T2 weighted imaging effects. What is a short TR? Well, if you were wondering, from for the magnet strengths we use, it's usually around 300 to 450 milliseconds. And why is it that? Because you can differentiate these things like fat, which has a relatively shorter T1, and liver and kidney, which have a little bit longer T1s, and things like CSF, which have a very long T1 and hence would not contribute to the signal on a T1 weighted image. Things with a short T1 are bright and contribute signal. So hyper intense on T1 is called T1 weighted shortening. If you want to be a real jerk, I knew an attending once that instead of saying bright or hyper intense on T1 weighted imaging, he would describe an abnormality as a mass that causes T1 shortening. Just to sound super fancy. I guess he was wearing his fancy pants. All right. Gadolinium artificially causes T1 shortening. So that's why we use it, right? T1 shortening equals bright. We give GAD, it shows up as bright on a T1 weighted post-contrast sequence. So here's again a graphical representation. So if they showed you an image here, or a spin echo diagram here, where you have a 90-degree pulse and a 180-degree pulse, you're immediately going to think this is a spin echo pulse sequence. Then if you look, if the TE is relatively short, the TR is relatively long, and the time we listen for the echo is short, i.e. very close to that 180-degree refocusing pulse, then you're going to guess, hey, this is a T1 weighted spin echo pulse sequence. So the good news is that I figured out how to add the Jeopardy theme song. I'm a big Jeopardy fan. Onto the questions. The bad news is I'm a complete idiot, and again I forgot to clear out the answers. So hopefully all of you got this correct. The correct answer was in fact fat. God, I just feel like Chris Farley from Tommy Boy. That's your assignment, is to watch that movie, which is a cinematic classic. I'm just so dumb. Why can't I just figure out how to clear them out beforehand? Anyway, whatever. Let's move on to T2 weighted imaging. This is a T2 weighted spin echo pulse sequence. T2 weighted images have a long TR and a long TE. Why do we not use a short TE? Well, at the short TE time period, there's really little time for loss of that transverse magnetization and little, T2 signal because of the free induction decay, little time to lose that free induction decay signal. So you really can't differentiate things based off of their T2 weighted properties, right? Because everything still has maximal free induction decay signal at that short TE time, so there's no T2 weighting differentiation. Typically a T2 weighted image will have a time to echo of greater than 60 milliseconds. What is T2 weighted imaging good for? It's good for evaluation of things that are fluid, like edema, because fluid and water specifically have relatively long TE times. So edema, looking at MRCP images, the biliary tree. Many tumors are often T2 hyperintense, like hepatocellular carcinoma. Many metastases are T2 bright. Neuroendocrine tumor metastases, schwannomas, nerve sheath tumors are T2 bright. There are lots and lots of tumors that are T2 bright. And some things, like benign pathology, is very T2 bright, like cysts. So cysts in the kidney, cysts in the liver are very T2 bright. Oftentimes, I'm able to give a differential diagnosis based off of the T2 signal. So if you take like a liver lesion, if it's extremely bright, I know it's a cyst or a hemangioma. If it's T2 mildly hyperintense, and I always use the example of the spleen, it's more likely to be a tumor or a malignancy. So I always tell my residents, when you're reading a liver MRI, look at the T2 weighted imaging. If a focal liver lesion is similar in intensity to the spleen, that's oftentimes bad, because benign things like hemangiomas and cysts are usually hyperintense to the splenic parenchyma, more similar to CSF. The closer a liver lesion is to CSF in signal intensity on T2, the more likely it is benign. Some tumors, on the other hand, like prostate cancer, are actually T2 hypointense. So if you're looking at a prostate MRI in the peripheral zone, The peripheral zone is normally very T2 bright, and if you see something dark, that means it could very well be a cancer. Here's an example of a T2 weighted image. This is kind of an extreme example, the MRCP sequence. MRCP sequences are basically heavily T2 weighted sequences, to the point that the only things you see are fluid, in this case bile within the biliary tree. It's a great way to look at the gallbladder, cystic duct, intrahepatic bile ducts. We use this to stage cholangiocarcinoma. You look at pancreatic cysts to see whether they're connected to pancreatic ductal side branches or the main pancreatic duct. Very useful MRCP images, just heavily T2 weighted. So T2 weighting, basically they have a long TE and a long TR, so that the only thing or the main thing contributing to signal at this time point are materials with inherently long T2 weighted properties, which are, CSF, gray and white matter. Fat has relatively higher T2 times compared to like liver and kidney, although not nearly as long as like CSF, of course. The high signal intensity is called T2 prolongation. So again, if you want to intimidate others and sound smart and be a jerk, instead of say something as T2 bright or T2 hyperintense, you can say such and such abnormality causes T2 prolongation. If you look at this graphical representation, why do we use a long TE and a long TR? So if you measure the signal up here with a very short TE, you're going to have really little T2 weighting, because even objects or tissues with a short T2 properties and long T2 properties will both have signal. There's been relatively little free induction decay process here. Whereas if you wait longer for a longer TE, right here, you've allowed those short T2 weighted tissues to lose a lot of their signal. So at this time point, the only things contributing signal will be the things with a longer T2 property, which you can narrow down your differential diagnosis. So you image out here with a longer TE and longer TR, so that you're T2 weighted, and you can tell the difference between tissues that inherently have long T2 weighted properties and those that have short, which have lost all their signal at this longer time point. So if you image right here and you look at this diagram here, let's say we imaged like right here. Right here, things that have a longer T2, like 50 milliseconds, will be bright. So if you go here, that means fat will be bright, but the liver and kidney will be dark. CSF will be bright. Edema, like fluid around the pancreas, will be bright. But things that don't have that long of a T2 will be dark. If you look at a spin echo pulse sequence, if you look at a spin echo pulse sequence and there's a 90 and a 180, you're obviously thinking of a T2 weighted image. And then if you see a very longer echo time here, then you're going to be guessing a T2 weighted image. The diagram they showed, I'll be fair, you're thinking to yourself, this looks exactly like a T1 weighted image, right? Because you can't really make out on these various timelines, when exactly this echo time is, unless they give you some idea. And I'll tell you, here's the way that I always cheated it, right? So if you see a 90 degree pulse and then a 180 degree pulse and then another 180 degree pulse, you're going to guess that it's T2 weighted. Frequently in the real life practical MRI land, if you see a 90, 180, 180, I would go ahead and guess that it's T2 weighted, because T2 weighted imaging oftentimes will use dual echoes or multi echoes after that, with an echo train length of a number of 180 degree pulses after. So that's my cheat hack way through life as someone that really doesn't know much about physics. If you see a 90, 180, 180, or 90, 180, and then a bunch of 180s, you're going to guess T2 weighted imaging. Proton density imaging, PD imaging. This is unique because it uses a long TR. That long TR allows for recovery of longitudinal magnetization, so it minimizes T1 weighted differences, and it uses a short TE, so that minimizes T2 weighted differences. So you're like, why on earth would we do that? We're minimizing T1 and T2, which inherently gives you little tissue contrast. Well, the reason we do it is mostly for structural imaging, because the signal that's generated as a result of this setup mainly depends on how many protons are present in a given area. Functionally, this results in everything having intermediate T1 and T2 weighted signal abnormalities, so you can't really get a lot of tissue characterization around here or around this using it, but what you do get is very good anatomic detail. So this is useful on things like joint imaging or a knee MRI in this example, because the hydrogen protons are the things that are giving you signal, and you can get good anatomic imaging. So if you're just looking for like structurality, did I make that word up? I think I may just have. If you're just looking at structural integrity of like the ligaments here, like the anterior cruciate ligament, you're going to do a PD sequence because you'll be able to follow those ligaments in good resolution and detail. Here's the PCL. You can tell that that's intact. So you don't really care about T1 or T2 weighted characterization. You just want to know what's there, and where the protons are can kind of tell you what's there, and it makes it very good for anatomic imaging, specifically musculoskeletal joint applications is frequently what proton density images are used for. Here's a graphical representation of PD imaging. So again, like if you have a long TR, basically most of the T1 weighted properties are gone because longitudinal magnetization is back. And if you pick a short TE, most everything still has all of its free induction decay signal. It hasn't had time to kind of repel apart due to proton-proton interactions, and so you're going to have little T2 weighted effects. So if you see something that has a long TR, short TE, guess proton density image. Frequently, proton density images are used with fat saturation as well. All right, the next pulse sequence to look at is a turbo or fast spin echo pulse sequence. These are very easy to identify, and they're really just a variant of T2 weighted imaging. So they are easy to identify. Why? Because you'll see a 90-degree pulse, and then you'll see a 180, and a 180, and a 180, and a series of 180s after it. The phase encoding gradient is changed for each echo. So if you'll look at the phase part of the spin echo pulse diagram, the phase encoding gradient goes up and down, up and down, up and down. That left to right direction or anterior to posterior direction, whatever you're using in the phase encoding direction, is switched for every echo. Why is this used? Well, functionally, it allows the whole pulse sequence to shorten in terms of the overall acquisition time. What it does is it generates multiple phase encoding steps into one TR, so it decreases the number of repetitions you have to do. So if you have to do less overall total repetitions or less TRs for a given sequence acquisition, it lessens the overall imaging time it takes. It introduces this concept called echo train length, and the echo train length is just how many 180-degree refocusing pulses do you do by the time you're done with the initial TR. The more pulses that are in, and generally the faster the sequence will be or is designed to be. It's always a trade-off, because if you do this too much, you'll lose signal and it won't work. So there's a balance between echo train length and the amount of signal you can get. Obviously, like really good setups with really good receiver coils that can detect low signal, and powerful magnets like 3 Tesla can do this turbo and fast spin echo sequencing to better advantage, i.e. allowing them to image faster. All right, where would you use a turbo or fast spin echo pulse sequence? And again, easy to identify. T2 weighted image, fast or turbo spin echo, because it's 90, 180, 180, 180. And then if you look at the phase encoding steps, it goes up and down, switches with every acquisition. You'd use these sequences in places where you need fast imaging, and it helps avoid motion. And we use them a lot in body imaging, which is what I kind of focus on. So think about the liver. The liver, as you breathe, is moving up and down along the diaphragm. So, you can do breath hold techniques, But people are pretty limited in how they can hold their breath, especially if you're cirrhotic with ascites, which is frequently what we're doing liver MRIs for. So you're really limited in how long people can hold still. And so T2 weighted imaging in the abdomen, for example, is usually a turbo or fast spin echo sequence. The next pulse sequence we're going to talk about is a gradient recalled echo, or a GRE. These usually have a low flip angle. So again, they're very easy to identify, because if they give you a flip angle, it's just called alpha here. But if the flip angle is like 10, 15, 20, immediately you're going to think, oh, this is a gradient recalled echo pulse sequence. It's easily recognized as well because there's no 180 degree refocusing pulse. So if you see a single pulse here and there's no 180, then you're going to guess it's a GRE. Again, like I use a lot of cheater things, or I did when I went through physics. If you see a 90, 180, it's a spin echo pulse sequence. You're going to think, oh, it's T1 weighted imaging. If you see a 90, 180, 180, 180, 180, you're thinking it's T2 weighted, a fast spin echo T2 weighted sequence. If you see just one radio frequency pulse and nothing after it, guess GRE, especially if that's at a low flip angle. GREs use very, very short TR times. GRE sequences are very fast. They allow for very fast acquisition. So, for example, a TR in a GRE might be 5 milliseconds. So you can do 256 image acquisitions in about a second. That's extremely fast. Doesn't require much of a breath hold, right? It's very reliant on the polarity of the magnetic field gradients. What does that mean? So that means it's T2 star weighted, not really T2, because it's susceptible to and people even call them, susceptibility artifact or susceptibility sequence. We'll get into that later. But because they're T2 star weighted, they're not relying on these phase-phase interactions, but more on magnetic field gradients. So on GRE sequences, if there's surgical clips, they can cause T2 star effects and look dark, cause some blooming. We'll talk about that more in the artifact lecture. GREs are different among different brands of MRI scanners, and they have lots of weird names. So they don't call them GRE because that would be too easy. Like Siemens calls them Flash. Some vendors call them FISP, Grass, Tiger. I think one of them out there calls them Tiger. They're just all basically a GRE sequence. Again, here this is just showing you, like Philips will call them FFEs or balanced FFEs. GE calls some of them Grass. They'll call them Fiestas. Basically, if you see a funny name, Flash or whatever, and you have to guess, then guess that it's a GRE or a gradient echo pulse sequence. Again, I like to put these mental health breaks into my talks. Feel free to skip over this if you think I'm dumb, which is perfectly acceptable. I've been out of ideas. I've done hundreds and hundreds of lectures over the last couple of years since I've been and attending. This is going on YouTube, and I have to keep it socially acceptable. I can't use anything that's offensive, right? I in the past I've devolved into talking about a turquoise shirt I got that everyone complimented me on. I've talked about spandex for men. If you haven't checked it out, I've converted all of my dress pants, all my fancy pants, and all my jeans, and all my exercise pants into something that has spandex or elastin in it, because that's much more comfortable. We could talk about that. I used to coach my kids' baseball game, and I used to kind of whine and moan a lot about how hard it was to schedule it. I'd frequently rag on our hospital's IT department. What am I supposed to do? So these are all first world problems, right? Worried about having to wear pants that don't have spandex in them. So, scheduling baseball games on a computer, my complaints are all first world problems, right? I have a very easy life. I don't have to worry about, having a car bomb go out in front of my car as I take my kids to school, right? Those are real problems. I have first world problems. like being nice and warm in bed but having to go pee. That happened to me last night. It was awful. Like, I'm so warm. It's kind of cold here in Nebraska this time of year, but I had to go pee and I had to get up and I got cold. It was really uncomfortable. Or like sometimes you're lonely but you really don't enjoy being around people. I'm sure that happens to you too. I got a dog, which kind of helps with that. There's nothing to drink at home except for an unlimited supply of fresh drinking water. Don't you hate that? I go to have dinner, and I was like, oh, can I have a soda, or I want like some tea, or I want some lemonade or something. It's like, we don't have any of that. I have to drink water that's clean and pure and doesn't have any diarrheal illness that will kill me in it. I've looked at everything interesting on the internet, and I still have 3 hours left at work. So that used to happen to me in other jobs that were kind of boring jobs, where I got ahead of the game. In radiology, we're usually pretty much busy all day, so I don't have too much time to surf the internet. And if I do, I usually have to just respond to boring emails because I'm a program director, so all I do is get 1,000 emails a day. Mom asked what I want for Christmas, and I can't think of anything. I had to make fun of my kids that did this one just a couple days ago because Christmas is coming up. And they're like, we can't think of anything. We're so persecuted. And then they're like, oh, my daughter was like, oh, I thought of something, Dad. I need a moped so I can ride it to school. I was like, oh, think again. Someone didn't refill the Brita pitcher, and now I have to wait 30 seconds for water. I catch myself doing this because we have this fancy fridge with a filtration system, and I just get infuriated about how long it takes to fill up my water glass. I forgot I was watching a recording and I sat through commercials, or maybe you forgot that you could just speed up and skip this whole mental health break. Maybe you should do that. I'm so hungry, but I don't want to cook. I opened a drop-down menu and the United States was not at the top. I mean, seriously, right? We have the biggest military in the world. Why can't we be at the top of those drop-down menus? My laptop is dying, but the charger is in another room. That means I have to get up and go get it. My husband does everything I ask, but I have to ask him. That's my wife's biggest complaint. And then this is a real pet peeve of mine. And no, I'm not in favor of making smaller cookies. I am in favor of making bigger cups. So you're telling me you have fights with water and not over it. This kid from Africa doesn't care about my first world problems. He's got much bigger problems of his own. Next question. The correct answer here, and pause if you need more time, is T2 weighted imaging. A lot of people historically have guessed proton density. So it's not proton density, this is T2 weighted. So if you look, and I wouldn't even try and memorize like milliseconds. I don't think that the board exams will expect you to know like this many milliseconds for T1, T2, PD. What they'll do is they'll show you a graph to make sure you understand the concepts, right? So if you look at the time of acquisition, it's a relatively long TR because all of the longitudinal recovery has occurred. So you can eliminate a T1 weighted image because there's really no T1 weighted differentiation here. This is a relatively longer TE. It's not a short TE because if it was a short TE like for say proton density imaging, there would be no T2 weighting, right? It would be somewhere closer over here. Here we've weighted relatively longer for our TE, and there's a lot of inherent T2 weighted differences between CSF, gray matter, white matter, fat. You would actually get a lot of differential T2 weighting by acquiring signal at this point in time. So the correct answer here is, in fact, T2 weighted. All right, GRE sequences. These are good for seeing T2 star effects. T2 star effects are accentuated on things like blood because of hemosiderin deposition. Gas also causes T2 star effects and blooming for various reasons. So if you're looking like for gas in the abdomen on an MRE, MR enterography, like looking for perforated Crohn's or something and extraluminal gas, this is a good sequence to use it for. In the brain, looking for hemorrhages, microhemorrhages, looking for diffuse axonal injury, looking for cavernomas is a good use for the GRE sequence. These are in general good for applications that need spatial or good time resolution. So things that happen really fast. So like cardiac imaging, is a frequent use for GRE imaging. Because you have to get, cardiac motion, you got to image really, really fast for it. So like some people call it like bright blood imaging in cardiac is a GRE sequence. Some vendors will actually do a GRE sequence that's kind of functionally T1 weighted because you can do it very fast. So if you need to do fast dynamic post-contrast sequences, like to get an arterial phase, for example, many vendors will use a variant of a GRE sequence. Again, you learn these things and you're tested on these things like GRE, T1 weighted, T2 weighted, proton density. In reality, like a lot of the sequences have become so sophisticated that there's like a variant GRE sequence that's T1 weighted, and there are GRE sequences that have both T1 and T2 weighted properties, like a Fiesta sequence, which is done in MRI enterography just to eliminate bowel peristalsis. So even if someone's moving around, breathing, has some rumbly, bumbly bowel, the Fiesta sequence is so fast, you'll get some good anatomic imaging. There are newer steady state sequences that are GRE weighted and have more of a T2 effect and less of a T2 star effect. Those can be used again for like cardiac imaging especially. There are a couple GRE variants which deserve special consideration. One is called the spoiled gradient echo. What is a spoiled gradient echo variant? It's where at the end of every cycle you put in a spoiler gradient or a spoiler that destroys all the residual transverse magnetization left. Those are easy to find because at the end of the pulse sequence there's going to be a spoiler gradient on. So after you've listened to this echo, at the end there's a spoiler gradient, and that's done just so you can functionally repeat the whole process faster. There's also something called the steady state free precession sequence. That's a GRE sequence where a steady amount of transverse magnetization is maintained in between cycles. It has superior dynamic qualities, so it helps out with cardiac imaging. And again, like there'll be a gradient that's just on at a low level the whole time. This isn't an example of one, but you would see an extra gradient on that's on the whole time during the example, knowing that that's a steady state free precession. What you gain in speed a lot of times functionally limits your tissue characterization. So like bright blood imaging, it's great. You can see the motion of the cardiac valves. You don't get a lot of inherent T1 versus T2 weighted tissue characterization. So you wouldn't, for example, look at a right atrial mass and try and figure out exactly what it is on a GRE fast sequence. But what you could do is you could look at it and see its movement. Like, is it protruding through the tricuspid valve plane during diastole and systole? So these sequences are used where speed is of utmost importance. Pause now if you need more time, but which of the following sequences is most likely to suppress signals from fat? The correct answer is a STIR sequence. That's short tau inversion recovery. So what are inversion recovery sequences? They are easy to identify because they start off not with a 90-degree pulse, but they start off with a 180-degree pulse. It uses an initial 180-degree pulse to invert the longitudinal magnetization. And it introduces another changeable parameter, the TI. So that's the time to inversion. It's the time of the 90-degree pulse after a 180-degree pulse. So a lot of times these look like a spin echo pulse sequence, with the only difference being there's an initial 180-degree inversion pulse. So 180, 90, 180, you're going to guess this is an inversion recovery sequence. The TI selection times allow you to selectively remove different things. So you could do a TI time which selectively removes fluid. You could do a TI time that selectively removes fat. Those are probably the two most common things that these sequences are used for. STIR, so STIR is a type of inversion recovery sequence. It's a short tau inversion recovery. It nullifies signal from fat. So this is like a STIR sequence in the spine. You can see here that there's cord edema, there was discitis osteomyelitis, retropulsed fracture fragments, cord narrowing and canal compromise. You can see that on a STIR. All the fat, like in the vertebral bodies, within the subcutaneous tissues, is nullified in dark. FLAIR is fluid attenuated inversion recovery sequence, that null CSF. So a FLAIR sequence in the brain. You can see that there are high FLAIR signal changes in the periventricular white matter. Easier to see here because all the CSF signal is nullified. Fat and tissue saturation. So a little bit about this. So fat tends to be bright on many pulse sequences. It's very abundant, especially in people like myself. It gets in the way and causes artifacts. There's multiple ways to do fat saturation. There are inversion recovery, where special RF pulses at the initiation of the sequence are used to nullify fat. There are also regional SAP bands, which you can use to eliminate artifact from high signal tissues, like Dixon sequences, which are basically a Dixon sequence is a complex mathematical way to remove fat. The key is that fat is one of the few things that are hyper intense on T1 and T2. It has a unique MRI signal, and it can be nullified. Right? All right. So here's a Dixon sequence. Dixon sequence is basically magic, where it creates 4 different images for you from the same acquisition. A water sensitive sequence where fat is nullified, a fat only sequence where water is nullified, in addition to T1 in and out of phase imaging, which we'll talk about later. All right, diffusion weighted imaging, DWI. It's where the signal is really based off of random Brownian motion of a water molecule within a voxel. A voxel is just like a 3D box, right? A millimeter by a millimeter by a millimeter would be a millimeter voxel box. The greater the cellularity some abnormality has, the more restricted movement it has, the more restricted diffusion it has. So if you have more cells within a small box, they're not going to be able to move around, and functionally they're going to create a brighter signal on diffusion-weighted imaging. What is the physics behind this? Well, the physics is an additional diffusion gradient is applied. So if you see an additional gradient here and it says D or diff on it, you're going to know that this is diffusion weighted imaging, right? So, this looks kind of like a pulse routine T1 weighted pulse sequence, 9180. The only key here is, there's an additional, in addition to your slice selecting gradient, your phase encoding gradient, your frequency encoding gradient, you have a new gradient, which is your diffusion gradient. Stationary water molecules tend to be unaffected by this and retain their signal. So only things that are kind of compact and, so stationary water molecules are unaffected by this. Things that are affected by this tend to be things that are really compact, cellular, tight in a box. And you can do differential diffusion weighted imaging. So here's an example. The classic example of diffusion-weighted imaging is used in brain MRI for stroke evaluation. In the kind of territory of a stroke, this is a right MCA infarct. The cells become relatively restricted in their movement. They cause restricted diffusion, and this is like the go-to sequence for looking for acute stroke. Also, prostate cancer. Prostate cancer is very cellular, so prostate MRI is very heavily dependent on diffusion-weighted imaging. It's really the detection sequence for cancer, and cancers will restrict diffusion on prostate MRI. Echoplanar imaging. That's where echoplanar imaging, or some people call it EPI, is formed by rapid reversal of the readout or frequency encoding gradient. So if you're looking at a pulse sequence diagram and you have a frequency encoding gradient that goes up and down, up and down, up and down, you're going to guess this is an echoplanar image. This can be a single shot or multi-shot, and that just refers to how K-space is filled, either one shot of it or repeatedly using multiple repetitions. What's the benefit of echoplanar imaging? Well, it's very, very, very fast. You can do these sequences in 20 milliseconds. What are they good for? Well, again, EPIs are good for doing things that require a lot of speed. However, they're bad in terms of they're very prone to artifacts. Oftentimes these don't turn out well at all, especially if someone has a lot of ascites and is breathing a lot, or other reasons. They're very prone to T2 star effects. They require very high performance gradients and special hardware magnets, etc. So I think I just misspoke where I said that if they have ascites and breathing a lot. What I meant to say is that they don't turn out if there's lots of hardware in place. So the most frequent problem I've seen in echoplanar imaging is if someone has a hip arthroplasty and you're trying to do diffusion weighted imaging to evaluate prostate cancer with echoplanar imaging being your technique. So echoplanar imaging is oftentimes used in a diffusion sequence. It'll just make it look like nonsense because the hip hardware is down there by the prostate gland. This requires a lot of complex gradients and math that's way beyond me. Here's magical ways that K-space is partially filled or filled in a spiral trajectory, which allows you to do echoplanar imaging. And again, echoplanar imaging is frequently used to acquire diffusion weighted images. So it's not 100% synonymous, but probably the most common sequence that I look at that uses EPI within it is a diffusion weighted sequence. So you can use EPI for diffusion. You can also do perfusion imaging, like if you're looking at perfusion in a brain tumor. You can use them in abdominal sequences and cardiac sequences where breath holds are needed to try and speed up the image acquisition. All right, next question. The correct answer is it is often used for diffusion weighted imaging, which is at this point in the lecture, are you just paying attention because I just talked about that? All right. The correct answer is time needed for sequence and patient motion. So the main difficulty for 3D versus 2D imaging is it takes a lot of time. All right, 3D sequences, that's where there are two orthogonal phase encoding gradients applied rather than just one, in addition to the frequency encoding gradient. So you obtain a whole 5 by 5 by 5 centimeter chunk of signal, or a 5 by 10 by 20, or whatever your size of your block is. It requires a 3D Fourier transform to reconstruct, so it's only been available with newer, better mathematical processing. When the data is reconstructed, this sequence is very useful because it's equal resolution in all dimensions. So it's truly multiplanar. So if you have a 3D sequence and you're looking at it in the axial plane, you can reconstruct it in the sagittal and coronal planes without losing any resolution. That's very useful to get one sequence and be able to get 3 planes out of it. The main con is it just takes longer. So instead of being your phase encoding step times your TR, which is usually how we represent how long a sequence is going to take, it's a phase encoding step times a phase encoding step times your TR. So it functionally makes it a lot longer. Most people cannot hold their breath for sufficiently long for a 3D sequence, so then you have to do a respiratory or a navigator trigger to make it work. What are the pros of it? Well, there's no gaps. You get a whole block of information. You can get weird oblique planes for things that if you're staging a cervical cancer and the cervix is not in an axial, sagittal, or coronal plane, it's off axis, you can get an image like that. You can do overall fewer sequences, and I think 3D sequences will become more and more common the more that we have technology available to make them useful. A lot of vendors are working on T2 weighted imaging that's 3D because a lot of cancers can be staged and looked at. Cervical cancer, endometrial cancer, prostate cancer, they can be looked at in multiple planes. And they are, you can get exact perpendicular imaging to these tumors, in the uterus, cervix, etc., which, normally those anatomic structures are not perfectly axial or coronal. Pause now if you need more time. However, the correct answer is a navigator echo. So cardiac motion, obviously you can do ECG gating. Inversion recovery and diffusion weighted imaging are just kind of nonsense answers. And navigator echo, what is that? So to do 3D imaging, you have to image for several minutes. People can't hold their breath. So you can do respiratory or navigator triggers. These are used to help control breathing movements or to account for breathing movements. Some sequences you just can't do a breath hold. So if you think about the respiratory cycle, at the down part of it here, you have a relatively still area. So at the down portion of the respiratory cycle, you accept all the signal that you get there because it's more likely to be while the person is still in between breaths. While they're actually breathing and moving their diaphragm, you reject all the signal from that time point because it's likely to be artifactual in a different spot than you want it and motion degraded. How do we do this? Well, one, you can just put a belt on a person and the belt senses diaphragmatic excursion, because your chest gets bigger and smaller as you breathe, and it only accepts at the down part of the respiratory cycle. Alternatively, you could do a navigator trigger. That's where you do a setup of the liver and you have the person breathe and you set up a box like this and you only accept signal obtained while the liver is in the certain portion of your pre-selected navigator trigger. Unless you're David Blaine, who literally, if you don't know about him, look him up, Google him, spend the next half hour reading about this amazing person. I think he's actually the devil, some of the stuff that he is able to do. But he held his breath for 17 minutes and 4 seconds. Quite remarkable. Special pulse sequences are going to be covered later by one of the other radiologists, things like fancy bold imaging, stuff like that. I will talk a little bit about magnetization transfer imaging. This was really in vogue for a while as a research protocol. It hasn't really panned out. This is used to modulate image contrast by saturating a pool of protons in macromolecules and their associated water. It's got very, very short T2 properties. It requires very narrow RF pulses. It's kind of experimental, used a lot in breast imaging and Crohn's disease. I doubt you'd be tested on it. Only be aware of it because maybe if it ends up working out, it'll be something that you'll have to use in the future. MRS is magnetic resonant imaging spectroscopy. I'm not going to talk a lot about it because, again, it'll be talked about more in future talks. It's where gradients are used along with RF pulses in a small rectangular volume, and you can detect slight differences in resonant frequencies based off of the metabolites that are present because they have slightly different proton configurations. So you could put like a box here, a small voxel in the brain, and you can see how much choline, creatinine, NAA is in there, lactate, and by its compositional makeup you can detect whether it's like a recurrent tumor or cancer or stuff like that. It's very time consuming. It's hard to read. You really need an expert. It needs a strong uniform gradient, and it's still mostly experimental. It was used a lot for prostate cancer originally, but that's fallen out of vogue now, and I personally don't use it for anything on a routine basis. So we're at the end of the Pulse Sequences lecture. Thank you for watching along. Really appreciate the time and effort you're putting into learning physics, and hopefully you got some benefit out of this.